Okay, everybody, we're going to go ahead and get started. I think I know most of you in the room. I am Stephanie Meyer with Learning and Intelligence. We've got our whole L&D internal team here today. I want to stand up. And the lady waving at us here today is our little Miss America. Not quite, almost.
Grandma America.
This is Ileane from our Les Turner Foundation, working with ALS, and from respiratory therapy, from health technology. So she's going to go through all of our machinery, I like saying that word, with us a little bit later in the presentation. So I'm going to let Ileane take it from here. She's going to give us everything we need to know, and then some. You're the expert. We'll try. Yeah, we'll try. So while we have them for an hour and a half today, they're going to go through their presentation, and then we're going to have some time for Q&A later on in the presentation. I'm going to let you take it from here.
Good afternoon, everyone. Thank you for inviting us and this opportunity to present end-of-life care for patients, or as we say, PALS, P-A-L-S, patients with ALS, a guide for nurses and other staff members. How many of you have dealt with or cared for ALS patients? Good. Great, that's good. Okay, we refer a lot of patients to you guys from the Les Turner ALS Foundation. Just to explain a little bit before we get started with advancing the slides. And is someone going to do the...
Oh, there's a clicker for you up there?
Oh. Which one?
Yeah. Oh. There are a few. Yes. My fault.
Up and side.
Forward.
Okay. The Les Turner Foundation is the fundraising arm of the ALS network, so to say, and we are funding, or we fund Northwestern's ALS program, which is now massive. We see hundreds of patients a year, and we are also at Northwestern, it's called the Lois and Solia ALS Center. So we do patient care. There are 3 research laboratories with probably close to 50 or more researchers, and a 4th lab is coming with our new director of the ALS Center, not just the clinic, but the center. Dr. Cobb is coming from the University of Pennsylvania, and he's bringing his lab. So that's going to make 4 research labs, clinical drug trials, patient care. So it's the Les Turner ALS Center at Northwestern. Okay, so just so you understand how we all work together. I'm part of the home team. I'm the manager of community education, and I'm also a support group facilitator. I'm still seeing a few patients, but not many, because I'm doing so many of these programs. We have 4 other nurses. We have 2 social workers that are part of our home team. Okay. So let's get started. What we're going to cover today is an overview of ALS, symptom management, and end-of-life care. And I don't want to be a talking head. Interrupt me at any time, please. What is ALS? ALS, amyotrophic lateral sclerosis, that's a mouthful. That's why we say ALS, is a progressive neuromuscular disorder that involves the degeneration of both the upper and the lower motor neurons, leading to eventual wasting and atrophy of all voluntary muscles, including muscles that are used for respiration. So, to have a true diagnosis of ALS, you have to have upper motor neuron and lower motor neuron involvement. Otherwise, it's a different disease. ALS occurs in roughly 1 to 2 per 100,000 people worldwide. That's the incidence. The prevalence, or people living with ALS in North America, is 5 per 100,000, and these are the newest statistics from the CDC, since we now have an ALS registry. The average life expectancy after diagnosis is 2 to 5 years. Disease progression is unpredictable. Approximately 10% of all people with ALS live more than 10 years. I just had a patient who passed who had it 22 years. So you might say, why don't we refer to the terminal disease? Why don't we refer to hospice right away? Well, we have slow progression, we have rapid progression, and then we have the average progression. So who gets ALS? 90% is sporadic. That means anybody. It can happen to anybody. 10% familial. So at Northwestern, one of our docs, world famous Dr. Steve, follows patients with familial ALS. So we have families that we've been following, or he's been following for over 30, 35 years, that I've been seeing for the 22 years I've been with the foundation. So very often you will get a referral of an FALS, a familial ALS. We have families that have 10, 15, 20 people in the family that have had ALS. So you'll see more from our referrals than any place else, because that's kind of Dr. Sadiq has discovered at least 4 or more of the genes for FALS. Slightly more male to female, 1.5 to 1. Incidence peaks between age 40 and 70, can occur in people ages 20 through 90. I've had someone as young as 13, and I've had someone as old as recently as 98. So you can't say it's a disease of one age group. It's more predominant in over age 55, but we see people of all ages. We have a lot of people in their 20s these days. Okay, clinical features. Weakness, cramps, fasciculation. Does everybody know what fasciculation is? Okay, it's kind of muscles, rolling muscles, twitching of the muscles. Those are called fasciculation. Spasticity, ease of laughing or crying, fatigue, musculoskeletal aches and pains. This is not the kind of pain of cancer pain. This is musculoskeletal. Presentation of weakness. Most patients first notice weakness in their limbs, about 32% in the upper extremity, and about 36% in the lower extremity. So that's like foot drop, falling can be first symptoms of lower extremity. Upper extremity weakness can be that people start dropping things with their hands. They can't carry heavy things. About 25% of patients present with speech or swallowing problems. That's called bulbar onset ALS. Okay? So very often those patients present, and they misdiagnose. They go to doctors, they think they've had a stroke. They work them up for a stroke or other issues like that. Okay, so bulbar onset also is they get a diagnosis sometimes of bulbar palsy, but that eventually will become ALS. Breathing is rarely affected first. In the absence of any other symptoms, about 7% present that way. I've been called to the emergency room or the ICU with people who are trached and vented before they have a diagnosis because they present with respiratory problems, repeated pneumonias, and so on, and eventually they will be diagnosed with respiratory onset ALS. Okay, functions rarely affected. We never say never, and we never say always. So functions rarely affected. Intellect. Some patients may have mild to severe cognitive impairment. Sensation, vision, bowel or bladder. Bowel or bladder, they can be a slowing down. They can get a neurogenic bladder, but rarely is it affected. Constipation usually is because they don't have the energy to push to eliminate. Sexual function is rarely affected. Functions never affected is heart, kidneys, and liver. Nearly all people with ALS develop symptoms of respiratory insufficiency. So this is what you'll see mostly on death certificates, and why we've had a hard time getting real numbers is because the death certificate will say respiratory failure, pneumonia. Very rarely will it say ALS. So the usual cause of death in ALS is related to respiratory failure. Ideally, people with ALS and their loved ones will be carefully educated about the disease, and that's one of the things we at the foundation, at the clinic at Northwestern, are very vigilant about, education. No secrets. All ALS patients need to to make a decision regarding choosing or not choosing invasive ventilation, invasive mechanical ventilation. Hospice is strongly encouraged for all patients who opt against long-term ventilation. Presentation of symptoms. People with ALS may have a variety of onset and symptom presentations. I'm a support group facilitator. I do 3 different support groups in the Chicago metropolitan area. I can have a table of 10, 12, 15 patients and their loved ones and their families. You go around the room the first time they can't say, well, how did you present? How did you present? Someone will say they started with tripping and falling. Another one will say they started with their hand weakness. Another person will say they have difficulty swallowing, slurring their speech. Another one will say, I have respiratory difficulties. That was my first presentation. So, this is the enigma of the disease. In the latter and end stages of ALS, patients may experience respiratory insufficiency, fatigue, problems with mobility, pain, dysarthria, dysphagia, problems with secretion, involuntary emotion expression disorder, IEED, otherwise known as pseudobulbar affect. You've probably seen the ads, the commercials on TV with Danny Glover about the new drug, new Dexta, for this syndrome, otherwise known as pseudobulbar affect, and it affects other neurological illnesses as well. People with MS can get it, people with traumatic brain injuries can get it, stroke can get it, but it's very prominent in bulbar onset ALS. Very, very prominent. So they're laughing when they don't want to laugh, they cry when they don't want to cry. Sometimes they cry and they can't stop, or they laugh and they can't stop, and they're not dementia. It's not dementia. This is part of the disease. Depression, insomnia, and constipation. These can all be effectively managed to allow the patient to remain comfortable and have a peaceful end of life. And that's why we're all here today, to assist them. Symptom management. Signs and symptoms of respiratory insufficiency. Shortness of breath, dyspnea on exertion, speech, eating, and ADL. They can get short of breath just by taking a shower, and that will be the end of their day. So shortness of breath is very evident after speaking a lot, after eating a meal, and so on. Waking up for frequently interrupted sleep, morning headaches, vivid dreams, hallucinations, and confusion. All can be signs of respiratory insufficiency.